All right, I'll start now.
Thanks.
Mhm.
Hello, everyone. Thanks for joining the webinar. We're just admitting everyone who's been in the waiting room. Thanks for your patience. We will get started in just a moment with our last session of the collaborative dialogue series on family planning in the UHC agenda. Just going to give a moment for a few more people to get in the room, and then we will kick it off. Okay, let's go ahead and get started. I can see that there's already a great group of you in the webinar room. Welcome, everybody, and thank you for joining us for our third in the series collaborative dialogue on family planning in the UHC agenda. It's always fantastic to see so many participants joining in and to have the panel that we've put together today as we discuss shaping policy programming, implementation and advocacy for family planning and universal health coverage. My name is Amy Baldasser-Bush. I'm a Senior Director at Management Sciences for Health. I lead our work on health policy, advocacy, and engagement, as well as integrated healthcare. I also oversee the work of the Civil Society Engagement Mechanism of UHC 2030. We're the civil society constituency of the global UHC 2030 partnership for strengthening health systems and achieving universal health coverage. The CSEM and our more than 800 member organizations in 100 countries advocate to ensure that UHC policies and programs leave no one behind. I'm coming to you live today from the World Health Summit in Berlin, where discussions about how we ensure no one is left behind, including in achieving universal access to sexual and reproductive health and family planning, are very much on the agenda. We've also been here advocating for the importance of social participation, which will be addressed by our panelists today. We have a fantastic panel, and I'm looking forward to the engagement of all of you in the discussion. Before we get started, I'd like to share a few reminders about today's webinar and how things work on this Zoom platform. The webinar is being recorded, and we're pleased today to be offering simultaneous interpretation in English, French, and Spanish, as well as access to closed captioning. Everyone in the room needs to go down to the bottom of your screen, look at the globe icon, and select your preferred language. When you do that, you'll see the English, Spanish, or French channels, as well as an option to mute the original audio if that makes it easier for you to hear the interpreters. If you need technical support with the interpretation, please feel free to put a message in the chat and my colleagues will assist you. In addition, you can also choose whether to see closed captions during the session. You should be seeing those captions automatically, but if not, you can click on the icon at the bottom of the screen that has two small letter C's and choose to turn the captions on or off. Those captions are automatically generated by Zoom, so they may sometimes have errors. And at this time on the Zoom platform, those are only available in English. Next slide, please. I'd like to thank our partners for the series, FP 2030, Knowledge Success, PAI, as well as our speakers who I'll be introducing to you shortly. The co-hosts are standing by to collect your questions and comments throughout the discussion, the panel today. So feel free to use the chat box at any time, and I promise we'll have plenty of time to address them and to engage with you. As I mentioned, and you can see on the screen, today is the final dialogue in our three-part series on family planning in the UHC agenda, which we've organized to bring the family planning community together in the lead up to the International Conference on Family Planning, which, as many of you know, will be taking place next month in Pattaya City, Thailand, and where the theme for this year is family planning and universal health coverage. This dialogue series will help to generate insights and content for a policy paper on family planning and UHC, which will help us to prepare advocacy messages leading up to next year's high-level meeting on universal health coverage. We'll be sharing a draft of that at the ICFP conference, and we'll launch that paper officially on International Universal Health Coverage Day on December 12th. If you missed either of the first two discussions that you see here, part 1 and part 2 on the screen, excuse me, don't worry, they're available on the Knowledge Success website. We'll share the link in the chat. You're in for a treat with today's session on creating demand for UHC, for family planning and the UHC agenda. Similar to our previous sessions, the agenda for today will be me posing a few questions to our really fantastic group of panelists. I'll encourage a little bit of dialogue amongst them, and then we'll have plenty of time for your participation. Next slide. The objectives for today, we're going to be talking about examples of leveraging community engagement to integrate family planning into UHC policy design and implementation. And we'll also talk about how to ensure inclusive access to services, centering a gender transformative lens, excuse me, and norm shifting to expand access to family planning as a component of UHC, with a real focus on leaving no one behind and achieving what the 2019 political declaration from the high-level meeting on UHC says, which is a promise from all member states to prioritizing reaching those left furthest behind in UHC first. I wanted to say that today's conversation is also very timely, not only with what's going on this week at the World Health Summit, but I think we've been reflecting a lot on our experience during the COVID-19 pandemic, which has shown that strong, effective health systems are the ones that are trusted by their users and are responsive to the needs of the populations they serve. WHO Director General Tedros is here this week, and he calls trust the most valuable commodity in health. And I think, as you're going to hear from our panelists today, the only way to achieve that trust is to have civil society and communities at the table to design primary healthcare systems that are responsive to their needs, engaging people as equal partners in promoting and maintaining their health as a cornerstone of UHC. And that's particularly important as we think about people-centered and rights-based approaches to integrating family planning in the UHC agenda. So I hope you'll join me in welcoming our panelists for today. The next slide. I will introduce each of them briefly now, and then we'll have 2 rounds of questions for them. Our first speaker will be Dr. Jose Ruales, the Minister of Public Health of Ecuador. Dr. Ruales, with training in medicine, surgery, and public health, has held senior positions in various government institutions in Ecuador and has served as a representative of PAHO, as well as a consultant for the World Bank in Latin America and the Caribbean and Washington, D.C. for more than 20 years. He brings over 35 years of experience in public health and has worked with ministries of health in most countries at this point in Latin America and the Caribbean region in the development and organization of health systems. We're very pleased to have the Honorable Minister joining us. Our next panelist is Dr. Nusrat Nasir. She's the Deputy Director of the Family Planning Association of Sri Lanka and a representative on the panel today of the SRHR and Gender Alliance on UHC. Nusrat's organization is one of the most expansive and well-known NGOs in Sri Lanka that focuses on family planning, sexual reproductive health, and welfare. She leads the organization's work on sexual and reproductive health service delivery, having worked in SRH and family planning for the past 7 years, first in the Ministry of Health and then in the private sector. Our next panelist is Deputy Minister Professor Rizal Demanik, who is the Deputy and Chairman for Training, Research and Development of the National Population and Family Planning Board of the Republic of Indonesia. He also serves as a professor of community nutrition and head of the postgraduate program in community nutrition at the Bogor Agricultural University. He has extensive experience in academic, research, and government roles related to health. And I'd like to congratulate Professor Demanik on Indonesia being awarded the 2022 United Nations Population Award for its incredible contribution to raising people's awareness about population issues and working towards solutions for those. And finally, we're hoping to be joined today, if her internet holds up, by Dr. Mariama Abdugado. She's the FP 2030 focal point for Niger, a medical student, and a family planning youth ambassador. Mariama is a blogger and a social activist for the rights of women, girls, and the inclusion of young people in decision-making bodies. She's currently a sixth-year medical student and is a member of the Investors Group of the Global Financing Facility as one of their principal youth representatives, and also serves as a youth focal point for the Ouagadougou Partnership and Family Planning 2030 in Niger. Welcome to our panelists, and thank you for making the time to be with us. I think we're ready to start with the first round of questions. It seems that we are having some delays with participation from some of our panelists. That's why we got started a little bit late. We were having some internet concerns. So I'm going to start with the first question. We're asking each of the panelists to reflect a little bit on why it's important for us to specifically emphasize family planning and sexual and reproductive health and rights when we talk about universal health coverage and achieving universal access to health for all everywhere. Nusrat, could I ask you to come in first and give your perspectives on that?
Sure, Amy. Thank you, Amy, for that. And hello to everyone, to all the respected panelists and the audience. So the emphasis on family planning and SRH when we talk about universal health coverage, UHC lays the foundation for promoting and achieving the highest level of health and well-being for all people, regardless of age or social group, without discriminating any kind, and plays a critical role in countries' progress towards sustainable development. As a part of the 2030 Agenda for Sustainable Development set in 2015 by the UN, it recognizes the importance of SRH, including family planning, for improving health and well-being and achieving gender equality, as well as the centrality of SRHR for accelerating progress towards sustainable development. And furthermore, the UN Political Declaration on UHC in 2019, countries agreed for SRH is an essential element of universal health coverage. So these goals and commitments demonstrate how UHC and SRH are closely linked, and that achieving UHC is not possible without inclusion of SRHR. Therefore, the sexual and reproductive health right agenda encompasses the important elements of health packages to all sectors of society. Therefore, we believe that if access to SRHR is denied for even a small segment of community, one cannot truly claim that universal health coverage is granted within that community. So sexual and reproductive health rights are an essential component of everyone's rights to health. To understand this, to realize this, that every individual must be free to make their own choices about their bodies and sexual reproductive health without any resistance from any form of discrimination, stigma, violence, and coercions. So there should be readily available quality SRH, affordable and accessible services and education and information to all people, irrespective of their age, abilities, relationship status, sexual orientation, gender identity, geographical locations, etc., and other statuses. So as Family Planning Association of Sri Lanka, we believe that reproductive health is a fundamental human rights of every woman and man throughout his or her life cycle. To conclude the response to this question, SRHR is an important and crucial element of universal health coverage because it lays the foundation for healthy, balanced, and productive life, leading to realizing the full potential of beneficiaries of SRH services.
Thanks very much, Nusrat, and an excellent, concise summary as to why it's important. Professor Demanik, I'm going to come to you next with the same question to give some introductory comments on the importance of emphasizing family planning as we talk about UHC and broader efforts to achieve universal health coverage. Please, over to you.
Okay, thank you. So first of all, I'd like to convey my gratitude to the organizing committee for inviting me on behalf of the government of the Republic of Indonesia in this webinar. So I would begin to, the statement that the International Conference on the Populations and Development, ICPD, in Cairo in 1994 has become a milestone for a new paradigms of reproductive health, where the 1994 Cairo ICPD agreement emphasized that reproductive health is a human right, and fulfillment of basic reproductive health rights includes the right of every persons, both couples or individual, to decide freely and responsibly regarding the number, but spacings, and right time to have children. So according to the existence of Law 52 of 2009, concern population development and family development. Population development aims to achieve a harmony and balance between the quantity, quality, and distributions of the populations and the environment. And family development aims to improve the quality of the family in order to show a sense of security, peace, and hope for a better future in realizing physical prosperity and inner happiness. And to reach the demographic bonus, human resources must be prepared. And referring to President Regulations number 18 of 2020 concerning the 2020 to 2024, our National Medium-Term Development Plan, or RPGMN, the BKKBN is mandated to contribute directly to 2 of the 7 national development or priority agendas in the RPGMN4 between in 2020 to 2024, namely to improve quality of human resources and support the mental revolutions and cultural development. The preparation of human resources begin with ensuring premarital health conditions, intervention during pregnancy, nutritional intake during childhood to primary and secondary educations. And Indonesia is currently entering the demographic bonus period, where the number of productive age group is greater than the number of non-productive age groups. In fact, the peak of the demographic bonus is expected to be advanced in 2030. And the momentum of the demographic bonus must be maintained and utilized effectively. So Indonesia's development in 2020 to 2024 period is aimed at forming quality and competitive human resources, namely human resources that are healthy and intelligent, adaptive, innovative, skilled, and have good personalities. One of the determining factors for creating the desired population structure is controlling the total fertility rate, or TFR. And over the last 5 years, TFR in Indonesia has decreased from 2.41 children per woman of childbearing age, and it is according to data in 2010, and then to decrease to 2.40 according to data in 2017, and the latest data shows the figure to be 2.38. This is a survey conducted in 2018. So in a relative long period of time, the birth rate becomes one of the determinants of population. One of the efforts to improve maternal and child health is how to reduce maternal and infant mortality, which is still high in our country. So the target for reducing the MMR, maternal mortality rate, is 183 per 100,000 live births, and reducing the infant mortality rate, or IMR, to 16 per 1,000 live births in 2024. These reductions in MMR and IMR must be supported by ensuring the health of mothers and children through pregnancy planning programs, and to prevent 4 T points, namely 4-2, too young, too old, too often, and too much. This risk can be minimized with the proper operations of the Bangga Kencana programs. And one of them is by ensuring that the individuals and couples have access to family planning and reproductive health information, as well as family planning services to plan the right time and spacing of pregnancy and ideal number of children. One of the ways to plan this pregnancy is by participating in the family planning program. This shows that the family planning services are important in health services, especially in efforts to improve maternal and infant health. Besides that, the family planning services have also been included in the National Health Insurance, or GKN, financing scheme, which has been listed in the Presidential Regulation number 82 of 2018 concerning health insurance. Health insurance is a guarantee in the form of health protection, so that the participant obtain health care benefits and protections in providing basic needs. So in the BKKBN strategic plan, it is stated that one of the BKKBN policy direction is to improve access and quality of comprehensive regional-based family planning and reproductive health implementations, and focus on target segmented. Family planning program services are very important in GKN, and access must be available for all communities in the territory of the Republic of Indonesia, even in the border and remote areas. Thank you.
Thanks, Professor, and thanks very much for making the connections across the continuum, the linkages of the importance of family planning for reducing maternal mortality, infant mortality, and other health issues that are covered under the broader UHC umbrella. I think important as we make the case for embedding a focus on family planning and SRHR in policies, as Indonesia has done. I think we're still waiting for the minister to be able to join us. So I'm going to go into the actual next set of questions for Nusrat and the professor, and then hopefully we'll have our other two panelists joining. So Nusrat, coming back to you, UHC, as we've been discussing here already this morning, means that all individuals and communities receive the health services they need without experiencing financial hardship, and those are high quality health services without experiencing financial hardship. I wonder if you can talk a little bit about, in your work, what all individuals and communities mean from an operational standpoint. We're talking today about not leaving anyone behind, but we know that many still are. Who decides about the services that are needed, and what does without mean when people are already suffering from financial hardship? Over to you.
Sure, Amy. Thanks for the question. But however, I'll break down into 3 answers to make clarification more clearer. So all individuals and communities in universal health coverage means that everyone, irrespective of their ethnicity, financial status, sexual orientation, and marital status, receive needed services without any discrimination or exclusion. While this appears to be achievable, it is one of the most challenging aspects in working on SRH for all, because there are individuals and communities face barriers to access to services. For instance, the young people are often not given services through our general routine clinical facilities. There are limited services for marginalized group and LGBTQI groups. And the SRH is often deprioritized in emergency settings also. So there are adolescents who may not receive the SRH information in schools in many parts of the world. Therefore, it is important to take into account the SRH needs for these diverse groups to bring about this universal health coverage. And how many are left behind from country to country and will always remain hard to quantify. There are some indicators that will give us an idea of this, like such as the unmet need of family planning, but this is just a baseline. It is a well-coordinated multi-sectoral efforts from health, education, and community sectors that will enable us to even come close to realize this needs. For instance, in Sri Lanka, the majority of the SRH services are provided to the communities through the Ministry of Health, the government, free of charge, especially considering the distribution of family planning services by the government network, which is done through hospitals, clinics, and more widely through the midwives, and all possible modern methods provided to the communities. It has been also recorded that over 70% of the current users in Sri Lanka, family planning current users, obtains family planning services from government institutes, the facilities, while the private sector supplies only a little more than 1/4 of the demand. Still, there is an unmet need around 7.5% in Sri Lanka. So a little bit about an organizational standpoint, given the decades-long work on family planning, FPSL, Family Planning Association of Sri Lanka, is the first organization that launched the family planning concept in the country. So FPA Sri Lanka prioritizes to provide sexual and reproductive health knowledge and SRS services to the poor, marginalized, vulnerable, and sexually excluded and underserved community of the country. So over the past decades of work, FPA Sri Lanka has worked strategically to identify these SRS service gaps in the communities. So the areas what we have identified are the industrial zones, there the apparel industries are located, and the estate workers where the tea estates are there. So we have our clinics located there. So this helps us to fill in the SRS service gaps to get a better coverage, and also to prevent the overlap of SRS service deliveries that is done through the government facilities. And this is one of our initiatives that aim to reach the underreached. Finally, on this, universal health coverage without means, when people are already suffering financial hardship, as you mentioned, access to SRS services are often challenging, especially to women and men and children living in poverty in developing countries. So, universal health coverage, it emphasizes that protecting people from financial consequences of paying for health services out of their own pockets reduces the risk of further being pushed into poverty. So when people have to pay most of their health costs through out of their pockets, the poor are frequently unable to obtain all necessary services. Even so, for the ones who can afford also face financial difficulties in the event of severe long-term illnesses, which could also result in range of negative outcomes if the access is barred due to financial burdens that people have to bear for their health services. So countries should adopt a robust financial structure with sustainable approach to address this. So a little bit on Family Planning Association, we have a social marketing program that kind of gives us the financial mechanism to support our clinical services apart from the grants and the restricted funds we regularly get. So this is, thank you, Amy. This is in brief, the response to the question, the second question.
Thanks, Nusrat. Very clear break, because I know we actually asked you 4 questions in one, so I appreciate that. And maybe just a follow-up. I heard you talking about, preventing overlap with the government facilities and the crucial work that your organization does to really increase access to those who are likely both to have challenges accessing services in public facilities or facing a very high out-of-pocket cost in the private sector access. I wonder, part of the discussion today is about social participation, right? The formal engagement of government with communities in terms of shaping what services need to be provided or letting the government know about those gaps. I know this isn't a question we had written down for you, but I just wonder if you can talk a little bit about, is there engagement between your organization or the communities, the marginalized communities that you're serving, with the government, with the officials who are shaping what's available in public health facilities? Are there opportunities to, bring the voices of those who are left out of these services to helping to demand that changes in the context of UHC in your country?
Actually, Amy, our Ministry of Health, the Health Ministry, provides these SRH services across the country through grassroots system, the midwives, as I mentioned, from family planning to maternal health. That is the primary care segment of the government, which I won't be able to give much of the insight. So the work, what we do at Family Planning Association is, we don't want to overlap the work what the government is doing. It's a fantastic work that I've been doing, and the health indicators, SRH health indicators of Sri Lanka is quite an achievement in the region. So given that as an organization, what we have identified is certain pockets of communities, like the apparel industries, where 70% of the workforce are women within their reproductive age group, and most of them are men and women who participate in the apparel industry, who are internally migrated population. So there are health clinics, but SRH specific health clinics are not, most of the apparel industry doesn't have. So that factor we cater there. And furthermore, in the estate sector, some of the health indicators, maternal mortality, MMR is quite high, maternal mortality ratio is quite higher compared to the rest of the country. So that is why we have chosen the estate workforce also. However, said and done, we also complement with the government some of our outreach work. We working together with the government facility also. So some of the clinics are complemented with the government facilities as well. So this is how we wanted to kind of fill in those service gaps to have a better coverage among the marginalized population, where difficult to reach population. Hope I answered your question.
Yes, it's very clear and puts the emphasis on the importance of organizations like yours in sort of ensuring that access to those who are less likely to have access to the centralized services, even if those provided are very good. Congratulations on that important work, and thank you. I'm going to turn now again to Professor Damanik. Professor, I wonder if you could talk a bit about how we individually and collectively challenge health systems and services centered definitions of UHC to inform the design and implementation of more people-centered and rights-based approaches to integrating family planning and universal health coverage. We just heard Nusrat talking about adapting and offering services that are people-centered, meeting people where they are. Welcome your comments on that question. Thank you.
Okay, thank you, Amy. Distinguished ladies and gentlemen, so in response to that question, in Indonesia, family planning has been included in the UHC scheme in terms of promotive and preventive services through two financing schemes, capitations and non-capitations. The capitations and non-capitation schemes for family planning services are held at the first level health facilities, while advanced level referral health facilities are through Indonesia case-based groups, or INA CBGs, which is an application that the hospital uses to make claims to the government. The capitations scheme covers financings for counselings, pills and condoms, and the non-capitations scheme covers including injection services, insertions, and removal of IUD, implants, vasectomy, and handling complications, and interval tubectomy services and management of side effects, complications, and failure to use are covered by the INA CBGs. In Indonesia, health insurance is administered by what we call as BPJS Health Social Security Administering Body, hereinafter referred to as BPJS Health, is a legal entity established to administer the health insurance program. Services guaranteed by BPJS Health consist of health service at first level health facilities, health service at advanced level referral health facilities, and emergency services, medicine services, medical services, and medical consumables, ambulance, health screening services, and other health services as determined by the minister. BPJS Health and National Populations and Family Planning Board, or BKKBN, have collaborated and synergized in regulating family planning services that are equitable and quality to all relevant targets, which has been agreed upon by both parties since the beginning of the establishment of BPJS Health in 2014 through a cooperation agreement between two parties in Indonesia. The agreement manages 7 duties and responsibilities of BKKBN and 4 duties and responsibilities of BPJS Health that must be carried out related to family planning services, National Health Insurance or GKN system. The duties and responsibilities that have been prepared and agreed upon by both parties are intended to avoid overlapping duties and responsibilities or throwing responsibilities when problems occur in family planning services. Therefore, it is hoped that quality family planning services can be easily accessed by all targets, both contribution assistance recipients and non-contribution assistance recipients. There are 3 of the 4 tasks and responsibilities that BPJS Health must carry out in terms of family planning services are first, provide information on health facility data. Second, socialize family planning services in National Health Insurance or GKN. And third, carry out the technical guidance, monitoring, supervisions, and evaluations of the family planning program in National Health Insurance, and carry out the technical guidance, monitoring, supervisions, and evaluations. Our institutions, BKKBN, also synergizes with the provincial government, regency government, and city government to support the implementations of family planning services through the Physical Spatial Allocation Fund, or what we call as DAK, and Family Planning Operational Assistance Fund, or BOKB. One of the efforts made to increase the coverage of family planning services in health care facilities, especially long-term contraceptive methods, is to provide supporting facilities for family planning services for long-term contraceptive methods, including mini laparotomy or tubectomy set, laparoscopy with a camera and monitor, vasectomy without a knife kit, implant removal kits, and IUD kits. And the provisions of such supporting facilities is sought through the Physical Spatial Allocation Fund of the Family Planning subsector, which is allocated to the district or city government. In addition, there is support for Family Planning Operational Assistance Fund, or BOKB, or Non-Physical Spatial Allocations Fund, which includes the Family Planning Service Operational Menu, consists of the distributions of contraceptive to health facilities sub-menu, coordinations of family planning services at health facilities, family planning service development at health facilities, and mobilizing family planning service such as IUD, implant, tubectomy, vasectomy, and implant removal, with the support of physical and non-physical spatial allocation fund budget. So in addition, BKKBN also procure contraceptive devices and medicines for all couples of reproductive age for free. in accordance with the mandate of Law 23 of 2014 concerning a local government. It is explained that the central government carries out the management and provisions of contraceptive devices and drugs for the needs of national couples of reproductive age. In the presidential regulations of the Republic of Indonesia, number 82 of 2018, concerning health insurance, status that provisions regarding the fulfillment of the need for contraceptive devices and drugs for health insurance participants in health facilities are regulated by the regulations of the head of BKKBN. Therefore, the provisions of contraceptive devices and medicines to support the implementations of the family planning program is carried out by the BKKBN. So BKKBN provides the supply of contraceptive, while the family planning services are covered in the National Health Insurance, or GKN. In the GKN system of financing family planning services, BKKBN is responsible for ensuring contraceptive availability through contraceptive devices and drugs, while BPJS Health covers services for assistance. For service tariff or non-capitations of family planning service borne by BPJS based on Minister Health regulations, which is number 52 of 2016. Therefore, BKKBN strongly emphasize the importance of cooperations with professional organizations and related partners and various NGOs in the family planning sector, and strengthening family planning programs in the GKN era through collaboration or increasing commitment of partners is very important and very much needed by BKKBN. This is because BKKBN cannot work alone to facilitate family planning services in almost 19,000 health facilities units spread throughout Indonesia. A total of 19,000 health facilities are currently included in the BKKBN registration system. Thus, BKKBN is expected to guarantee the availability of contraceptive devices and drugs in each of these health facilities, including the preparations of supporting facilities, as well as strengthening the capacity and competence of human resources or health personnel for family planning services. That's all, Amy. Thank you.
Thank you, Professor. And it was, I know there's a lot of interest. I see questions already in the chat about the JKN, about the financing schemes in Indonesia, the advances you've made, as you said, in covering both contributing and non-contributing recipients. It was also fantastic to hear about the broad range of contraceptive choices made available with support of your programs, and we'll come back to that when we get to the question and answer session. So thank you very much. I'm pleased to welcome now, on behalf of the Ministry of Health of Ecuador, Karen Bonbon, who is the Director of International Cooperation. Karen, are you there? I think I saw you joining the video. The Minister Rurales has been delayed.
Hola, muy buenos días con todos y con todas.
Hello, good morning, everyone. I'm here on behalf of the Minister Jose Ruales. Unfortunately, due to some personal issues, he was not able to be here in the panel, but he would like to apologize for not being here, and we will send each of the annotations and arguments that he was going to disclose to everyone in written. Thank you very much.
Thanks, Karen. So are you able to join us and answer some of the questions that we were going to share with the minister, or do you prefer only to share those in writing? I think it would be wonderful to hear from you a bit about the work in Ecuador, but I'm not sure if you are prepared to do that or not.
Bueno, yo preferiría
Well,
realmente pasarles por
I
escrito.
think I would rather send the response in written, because the way that we work with is different. So I would rather send the response in written.
Okay, that's fine. Thank you. And we understand it's quite early in Ecuador and also a busy day for everyone. So thank you for joining in to bring the apologies of the minister,
Gracias
but
a
also
ustedes.
thanks, sharing that work. So now I'm going to
Gracias
move
a
on.
ustedes.
Thank you. It's come up a little bit already in the discussions that young people are often among the populations who are left behind or having challenges in accessing family planning services for a number of reasons. And I'm going to invite one of our co-hosts for the session, Adebiyi Adesina from PAI. Hi, Biyi, to come in and speak to us a little bit about actions that are specifically needed to ensure adolescents and youth are engaged in UHC discussions and that youth's family planning needs are included in the UHC agenda. I understand that Mariama is having some challenges joining from Niger, but all of our partners work closely with her. So thank you, Biyi, for bringing in some perspective on the needs of adolescent and youth. Over to you.
Thanks so much, Amy. Good morning, good afternoon, good evening, everyone. It's a pleasure to be part of this and to speak on this issue. I think the first thing I want to talk about is the fact that in every analysis that we've seen on the need for family planning, youth unmet need for family planning is massive. It is one of the key issues of ensuring our ability to meet the goals of the EPI 2030 initiative and global efforts to expand access to family planning. So it is evidently important to ensure that youth coverage is included, and to ensure that youth coverage is included, and to ensure that youth are able to take part in every opportunity in education, in whatever the case, to be able to build their capital, their human capital, requires that we provide the financial resources for them to do so without the possibility of financial destitution. So that would mean expanding UHC to cover youth. So in effect, UHC is a key part of ensuring youth access to family planning. Across the world, one of the key parts of what we're trying to do is ensure that every aspect of family planning services are included within the UHC package of services offered and provided to youth. And part of that will require that that governments and funders think about ways to ensure that youth access is included as part of the UHC reform policies. And to that extent, obviously, that would mean creating specific channels for that, for youth access. So in PAI's history of working with youth organizations, one of the things that we discovered in ensuring youth participation in these decisions is one of the key parts of what we've heard from our partners is that for youth to be able to fulfill their potential, as I said earlier, to be able to go to school, complete their education, and have opportunities to increase their capacity, that means that governments have to make weigh or make possibility there, the government have to provide the financial incentive to be able to seek services without the fear of stigma, without the fear of financial burden. And so to do that, we've been working with our partners to see how youth inclusion in those decisions are made, and to understand and document how best as possible to ensure continued youth access to family planning. One of the key lessons that was learned in the initial part of the global initiative, the EPI 2020 initiative, was youth participation was necessary from the get-go, and they learned that lesson within very quickly, and included a youth focal point in each country and at the global level. And that has brought so much more information into, much more insight into ensuring that the youth population, the youth demographic, have not only access, but have a say in how that access is done. So I guess my overall point is to say that, yes, without a doubt, UHC family planning access aren't possible at all if the youth are not included. Back to you, Amy.
Thanks, B. Thanks for sharing that. And we now have quite a few questions coming into the chat after these interesting presentations that sort of give us a range of perspective about different country approaches to supporting access for all segments of the population, including the importance of youth access. So I'm going to start turning to that Q&A. B, I hope you can stick around as we go into that. Professor Demanik, the first question that came in is for you. There's a question about how the government ensures comprehensive sexual and reproductive health services, including contraceptives, are made available during various disaster responses. The person submitting the question notes that there are a number of NGOs like PKBI and UN agencies, including UNFPA, that are promoting the MISP, the Minimum Initial Service Package, during the response, and work closely with BMBP and through a cluster mechanism advocating for an inclusive response to GBV. It would be great to hear from you about any kind of commitment from the government, such as allocated budget for that work on the MISP in disaster response planning. Over to you.
Okay, thank you for the question. That BKKBN has long been concerned about providing family planning services to disaster victims, such as during the great tsunami incidents that occurred in Aceh in 2006. We directly send health workers to refugee shelters to provide contraceptive services to couples of children's age who need services. And currently, BKKBN also has a directorate that focus on handling family planning services in underdeveloped or remote or border areas, including areas experiencing disasters. So we already have a guide for that too. Back to you, Ami.
Thank you. Thank you, Professor. The next question is for Nusrat. Nusrat, could you comment on if you're seeing a market segmentation within the private sector, with commercial private sector addressing those economically advantaged population segments, and groups such as Family Planning Association of Sri Lanka addressing those who are left out of the private sector entirely? And to what extent is there an overlap between your market segments and the public sector? I know you did talk a little bit already about how your organization is filling that gap, but I wanted to share this specific question on market segmentation. Thanks.
So Family Planning Association of Sri Lanka is an NGO. We are a non-profit organization. As I mentioned, for financing mechanisms for sustainability planning, we have the social marketing program for the financial sustainability plans. So FPSL falls in between the state's free services and private sector expensive services. While we have also non-refusal policies for most of our services in main clinics, and we also have this very subsidized fee for affordable rate to clients. Saying that also we have the outreach services which we provide for free of charge. When it comes to commodities, as I mentioned, the commercial market, the social marketing program, we have this unique pricing model which market it to affordable to the clients as opposed to same products marketed by commercial sector. Because of our suppliers give us the special pricing considering our non-profit status. So we therefore feel this gap of access to segment who can afford to pay a low fee for convenience and time-saving elements associated with other products and services. So we have wide range of services through the social marketing program. So there are affordable, very subsidized market products such as some condoms and oral contraceptive pills as well. So we have both market range, but our outreach work at the clinical setting is mostly we follow non-refusal policy, or we provide services at a subsidized rate at our main clinics.
Thanks, and thanks for providing. I think it's really exciting to hear that model, that social marketing model, and the complementary systems within Sri Lanka. A question for BE. As SRHR, there's sort of a few that are related to how we ensure or support adolescent and youth access to contraceptives, given the presence of laws or policies which may hinder those. There's a specific question about, as SRHR practitioners, we're obviously all on board with ensuring access to private and confidential SRHR services. Youth who are on their parents' insurance may not have access to care directly. More importantly, are we seeing a movement in including comprehensive sexuality education in UHC, or in a multi-sectoral effort across other sectors? I know you've spoken in one of our previous conversations about the different financing options for achieving UHC, and certainly this challenge around parents being the insurance holders is one of them. So welcome your perspectives on that.
Thanks so much, Amy. And that's a great question, and a challenging one at that. One of the key pieces of what our partners have been doing, and it's PAI, where we've worked on our UHC Engage project, has been ensuring that the inclusion of not only just family planning services, but a comprehensive SRH services and programs are included as part of the benefits package for the UHC reform policies. As part of that, our partners have also been working on creating awareness around ensuring on translating what access truly means to every demographic within each country. And that often has been working with different groups to explain and expand the definition of comprehensive sexual reproductive health services and programs. And so some partners have done is either work with faith-based organizations to reach out to ensure that parents are aware, and that services that are built in create some level of privacy within youth access to SRH services. Now that has had varying degrees of success in different countries. In some countries, there have been obviously challenges, but we're still getting information. We're just now receiving additional information on what those one of the key parts of the challenges are. On one hand, one of the key parts, as the question mentioned, is parents want to be informed about what services their children are receiving. On the other part of it is that the government's fully aware that youth have a right to access with some level of privacy. So there's a struggle around ensuring that issue is addressed. So our hope is that by the ICFP conference, we'll have more information to share from our partners on what that experience has looked like, what that experience looks like, and more importantly, that we can, by identifying those challenges, we are better prepared to address them, and we can outline what those key pieces are and how we are better able to address them. Thank you, and I apologize, I didn't have a more robust, a more happier ending response to that question. It's just been a really challenging process in different countries that we're working on.
Thanks, B. I think you highlighted that tension appropriately. Professor Demanik or Nusrat, would you like to come in on that question as well? Your own reflecting, if at all, on your own country experience in dealing with how, with the challenges that adolescents face to accessing family planning services, including potentially through the way the social health insurance is structured? Just building on B's comment.
Sorry, Amy, I need my cable, the charger. I'm looking for the charger.
Okay, go ahead. We don't want to lose you. Nusrat?
So Amy, I'll add a little. I may be not the right person to answer this. We have youth-friendly service centers, which are located within the hospital settings, but accessing them by the youth is quite a little of a issue, because not many openly access these services for discussion on contraception because of the cultural taboos and cultural resistance. Youth face directly contact their service providers for these services. However, said and done, but these services are there. So there are, I mentioned the grassroots system, the medical officer of health system, that is the government facilities. They have services for the youth, which is across the country. What we have in FPA Sri Lanka is we implemented, initiated a hotline service, which is called the Happy Life Call Center. It was initiated in 2009, aiming to provide confidential information in anonymous space for youth. Basically, it was aiming for youth community, but however, it is open to anyone to call us and find out certain information related to SRH and contraceptives, etc. So that platform, FPSL, we introduced in 2009. Of course, we get calls from everywhere, but this was one of the initiations which was done for the youth to access information for SRHR. But however, all our clinics are open. There are youth-friendly services, but for other reasons, they find it difficult, as previous panelists also mentioned. There are issues directly coming, and the confidential space is an issue, the privacy, all that matters to youth, especially when they come for these services.
Thank you. I think that was a terrific addition. Professor Demanik, are you back and plugged in? Do you want to come in on that question, or shall I move to another question? Maybe we'll keep going because there are lots of questions coming in the chat, and we really appreciate that. There are a number of questions. I would open this up to anyone who wants to address it. Talking about, we did hear from Professor Demanik already about response in disaster planning, for example, but I think as we're thinking about populations who may have limited access, there are a couple of questions coming in about current trends in migration, movement, displacement, young people who are living in crisis zones, and how we can ensure access to family planning among those populations on the move, including young people, but all of those that are faced with that displacement. I think it's important to note that, again, member states in the political declaration coming out of the high-level meeting in 2019 on universal health coverage made a commitment to ensure that universal health coverage, the promise, is also met for migrant and refugee populations. Interestingly, it's actually in the same part of the declaration where they talk about endeavoring to reach the furthest behind first. So this is a very important and perhaps, challenging segment of the population to reach. I wonder if any of you would like to respond to that question, or share some examples of best practices on how that may be done, or some of the specific challenges in reaching displaced migrant or people who are living in crisis settings. May not be the area of expertise of all of our panelists. Dr. DeMonica, are you back? B, anything to add on that one from your work on the financing? It may be a little bit outside the area of expertise of our panelists.
Yes, hi. So yes, it's a little bit outside of the work that we currently do, but I can reference data that that I've worked on in the past and often read. So one of the key issues around this has been trying to ensure resources are available, consistent resources and sustainable resources are available for those contexts and situations. And the challenge has often been that it's been difficult to ask governments to invest money, governments that are experiencing conflict, to have resources available. So one of the challenges has been ensuring that the global community has the funding available and the mechanisms to deliver that. And that often has gone through either the International Refugee Committee or through other sources. And my understanding is that quite often now that process has been to build the existing mechanisms for funding, either through multilateral banks or through bilateral aid. But with the advent of the COVID pandemic, the challenge with that has now become that most countries, a lot of countries are now in an economic downturn that has compromised their ability to be able to be able to shore up funding for those services. And so there's now the conversation going on about what that would look like. And unfortunately, we still don't have clarity on what that is. I will say that there's certain countries where conflict isn't entirely across the entire country, but within isolated parts of it, that are making efforts to provide resources for comprehensive sexual and reproductive health services, and they're to be applauded for their efforts. But certainly, I think it's important that there needs to be global mechanisms, clear and consistent and sustained for the long term. And we want to ensure that conflict isn't a part, isn't a detriment to health and access to health and resources. So yes, there needs to be a greater effort and advocacy around that. Back to you.
Professor DeMonica, do you want to come in on that one? Please.
Yeah, regarding the adolescents, then the Indonesian government has developed a program specifically for the young generations, what we call as genre. Genre is stand for generasi berencana, is a planned generation then. And the goal for this youth genre is giving informations and knowledge mindset for adolescents, for planning their family life and to make them ready to marry on time and in time, and relates to stunting preventions with future bride and groom through what we call it as LCMIL applications. Yeah, these applications are provided for the future bride and groom. So 3 months before they get married, the future bride and groom will have kind of monitoring health status, nutritional status, right? So they still have time if the result of this application inform us that they will, has a risk of stunting then. So also in January, we provide the services to young people in terms of behavior change, such as informations on family planning and contraceptions, but the services are for eligible married couples. That's my comment. Amy, back to you.
Thank you.
I saw another question. Is it for me or from Machumu Miyeye?
Yeah, there are many of them popping up. I'm getting through them as quickly as I can. We're collecting them in another document, so then I'm trying to respond to them as they come in. If there's another one that you see that you're particularly interested in answering, I welcome you to do that. I'm gonna ask another earlier question first, and then we'll come back to that. We still have a little bit more time for the Q&A. Wanted to pose a question to all of you, and this maybe we can start with Nusrat on this one. There's a question about any specific programs that are implemented or success stories you might want to share on increasing access to family planning for marginalized groups such as LGBTQI+, people living with HIV, people living with disabilities. We've spoken specifically about young people, but there's some interest in hearing about outreach for other groups that we know may historically experience challenges in accessing family planning. Welcome any of you to come in on that, but let's start with Nusrat. Go ahead.
Yes, so Amy, in all our clinics, we have not, it's an inclusive, like everyone can walk into our clinic and get any services, all the contraceptive services and all, especially transgender population. We had this, they used to come for regular clinic visits for testing and some managements as well. Further than that, we are also a part of the Global Fund program on HIV. So we have specific clinics that are supported by the Global Fund, which are running our clinic premises for HIV screenings for key population. So that is also an ongoing project. For people living with disability, recently as for the response for COVID-19, what we incorporated was home visit service delivery model, where we have our service providers visiting home, because people living with, it was mainly aimed to reach out to people living with disability to access those services. Furthermore, we also incorporated, these are all new initiations, what we started during COVID-19 to access, to increase the access, to reach out to the clients for these services. So one was the courier, one we incorporated courier service, home visits, and also community-based distributions to voluntary health assistance. These are some of the programs we incorporated. Apart from that, for LGBTQI population, the key population, there had been outreach work also for testings and screenings for HIV-related work. So it is ongoing. So we are trying to incorporate more programs, also even awareness raising programs on SRH. We kind of linked sign language interpretation for awareness raising in our social media as well to increase that viewing and reach among the population. Over to you, Amy. Hope.
That was great, Nusrat, and actually thank you for bringing in the importance of increasing that access even during COVID. It's been really interesting to hear about your hotline approaches, the home delivery, thinking about these innovative ways of reaching people when additional challenges are placed on access. Thank you. Professor Damanik, do you want to come in on that one as well? Was that the question you were seeing of interest?
Yes, the question is from Muchumu Mieye, right? About the sustainability
Yes.
of United Health covers in the family planning. So to respond these questions, Amy, the government of Indonesia allocate the budget for free contraceptions for all eligible couples nationwide. BKKBNs brings good work relations with our professional organizations such as doctor, midwives, and also Ministry of Health to collaborate in delivering services. And as I mentioned earlier, through allocated budget through the operational costs, we fulfill the need for technical family planning services at districts, and also collaborations with the BPJS for eligible family planning service to be covered. Meanwhile, certainly there are many other private schemes for covering family planning services for middle and upper income and couples. So our government has guaranteed the continuity of the family planning program in UHC because it has been included in our government's long-term development plan, including the budgets, which has been included in the National Development and Expenditure budget. So we also already have a budget for family planning services to districts. That's responded. I would like to add. Thanks, Amy.
Thanks for picking up on that question on the sustainability of the financing and the UHC services. I have time, and I see there's lots of interesting engagement in the chat too around some of what we
Hi, everyone. Sorry about that. I believe we're having some technical difficulties on Amy's side. So just, I guess, give us 1 second to get that organized. And oh, maybe Amy, are you back now?
Sorry about that. I'm in a hotel room and I just lost the internet. I thought it was going to hold out for the whole call. We almost got to the end with no issues. I apologize for that. So I was asking a question about in incorporating universal health coverage that incorporates comprehensive sexual and reproductive health services. Have your governments run into any challenges with existing laws or regulations that you find don't align to human rights standards? Or are there laws and regulations already in place? I know, Professor Damanik, you've spoken about a number of the laws and regulations in place in your country that enable gender transformative universal health coverage. B, I don't know whether any of your particular research on SRHR and work has lifted up some examples of those existing laws and regulations that are perhaps in conflict with what we're trying to achieve, or else we'll open that up to the other presenters. We can see you. Go ahead.
Excellent. Thank you. I wasn't sure if the question was to Professor Damanik first or to me. So yes, there are certain conflicts with with access to a broad set of comprehensive reproductive, sexual and reproductive health services. One of the key issues that we've faced, and this relates particularly to youth access, that we've seen is there are laws preventing, say, for example, comprehensive sexual reproductive health education at certain levels. And of course, one of the key areas of ensuring access to awareness about access to services and for example, to family planning contraceptive services is for youth is in the school environment or in the learning environment where they're able to better understand, where they're able to understand the breadth of services that are available to them, as well as the use of it and just basic comprehensive sexual reproductive education. What we've found in certain countries is that there are laws being have been enacted or are being enacted to prevent comprehensive sexual reproductive health education at the school level, which is an impediment to increasing youth access. And so in some countries, what we've seen is sometimes those anti-comprehensive sex SRH education laws are ignored, tacitly ignored by countries, and or are not persecuted. And so some partners are able to continue to provide comprehensive sexual reproductive education. Or in other countries, I know I may not be able to speak to the specific country, but I know in one particular case where a number of partners, including an international partner, were working with the government to provide not only comprehensive sexual reproductive health education, as well as contraceptives at the secondary school level, were immediately prevented from doing that, were suddenly prevented from doing that by certain political actors who decided to interpret the existing law, which didn't specify preventing comprehensive sexual reproductive health, and basically interpreted and said that that was increasing immorality at the secondary school level. And so we've seen these challenges come in different ways. And to be honest, one of the key things that one of our partners that we learned in their case was that there's no way to foresee how those challenges will come, but it's important that whatever family planning, whatever sexual reproductive health policies are enacted, have to think broadly about the implications of providing particularly youth with services so that it's represented as a right rather than something that can be easily taken away. So that's one of the key challenges in terms of either designing or implementing any policy reforms. I'll pass that back to you.
Thanks, B. That was great. And that also touched on some of the comments coming up in the chat, experiences in South Sudan and DRC and comprehensive sexual education. Yes, we're almost out of time. So Professor Demanik, over to you for a final comment on that one. Yes.
Yeah. Okay, about the vulnerable groups then. The government of Indonesia, based on the Indonesia law number 52, year 2009, stated that contraceptions is for eligible married groups. We understand that all citizens should be also taken into account their needs on family planning and services. And for those vulnerable groups, there are NGOs in Indonesia related to family planning and reproductive health that embrace their role to support their needs. And so the key point is that the government should embrace its collaborations with NGOs, CSOs to help fulfill family planning need and services for the youth. The highlight is for the knowledge and mindset, not for family planning services. The family planning service only for eligible married couples. And that's my add, Amy. Thank you. Thank you very much for the time.
Thanks, Professor Demanik, and a great way to sort of wrap up the conversation, putting some emphasis as we started on the important role of all stakeholders of government, of civil society, of public and private sector facilities to increasing access. Thanks to all of our panelists for a very engaging discussion, for answering difficult but important questions and looking at the inputs from those who are participating today about the particular challenges in their own contexts. I want to thank also our interpreters for the day, doing very hard work in helping us to increase participation and understanding of all participants. And thanks again to my co-hosting organizations. We will be sharing Knowledge Success. We'll share the recording of this presentation with you, and we'll be sure that the website also includes the presentation from our colleagues in Ecuador. I'm sorry that we weren't able to bring that work to you because I think that their emphasis on engagement around sexual and reproductive health and rights, including for people living with disabilities, is very relevant to the conversation we had today. And I have gotten another message sharing the apologies from the minister that he was unable to join. We'll also be amplifying this discussion on social media, so we encourage you to help us share it. I do want to put in a plug, a reminder about the importance and the opportunity of making an organizational commitment to FP 2030. Commitment makers will be highlighted at the upcoming International Conference on Family Planning. I know that PAI and Management Sciences for Health are amongst those renewing our commitments, and we encourage you to join us in that space. After this dialogue, we'll also be sharing a key takeaways document for use at the conference, and we'll be launching, as I mentioned at the beginning, a policy brief during UHC Day. I look forward to seeing many of you in Pattaya City in Thailand next month, either in person or virtually. Lots of opportunities for engagement in the conference. Please come and connect with us as the co-host, and let's continue these conversations around UHC and family planning. Thanks everyone for your participation today, and thanks to the organizers behind the scene. This takes a lot of work to bring it to you. It's been my deep pleasure to be with you for all three of these dialogue sessions, and we look forward to continuing the discussion as we move in the year ahead into planning for the high-level meeting on universal health coverage in September of 2023. So thank you all again for being here, and we'll see you in a few weeks at ICFP. Goodbye.
Goodbye. Thank you, Amy.
Thank you, Amy. Thank you.
Thanks
Very much.
again, Nusrat, Professor Demanik, Biyi.
Thank you.
Thanks for stepping in. Thank you all.
Thank you. Thank you.